You're University of Toronto, right, Vitor?
Yeah.
Okay. Gonna put this on YouTube. Come on. Okay.
Okay, let's
Hey,
start.
you ready to start? Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from, hold on. Let me start. Hold on, Vitor. Let me introduce before you start screen sharing, okay? Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach. We have the pleasure of having Vito Pereria, a big name in neurosurgery now, and I'll let Abdel introduce him. Okay, Abdel, it's all yours.
Okay. My name is Abdurrahman El Eter, Vice President of Wilterton, Yemen. I am very proud to present Professor Mendes, Director of Endovascular Research and Innovation in the Michel Hospital in Canada. He will talk about interventional neuroradiology of stroke.
Thank you very much for the invitation, Abdel. Thank you, John, for the organization. I will share my slides right away. So I work in Toronto, Canada. I'm Brazilian neurosurgery trained. Then did my fellowships in France. Used to live in Switzerland before I moved to Canada. So I've been abroad quite a while, and now I'm a co-director of the LINK series of meetings. And I also have a research lab. It's called Rage's Lab. And I do a lot of research in the field. This is the picture of this hospital, and we have the hospital and the research institute just side by side, which facilitates the research endeavors. Talking about endovascular, I have here a map of the evolution of aneurysm treated in North America. And it has grown successively towards endovascular. And on the stroke side, I think there's some more, there's something on the screen.
Okay. You want to click on the right side? That might help.
Just stop sharing. It's something on the screen.
Yeah. You want to start sharing it? Restart. Yeah, restart. Try it now.
Okay. The whole story of stroke treatment actually started in 1995. So there was a study called NINGS that was the first study that validated the treatment for stroke. And then stroke started being treated. When I did med school and neurosurgery, in my first year of neurology, stroke patients were not treated at all. patients would come with a stroke. I witnessed that phase, and actually it was striking because we knew there was a blood clot. The cardiologists were doing a great job on removing blood clots from the heart and treating the heart disease. And in the brain, we were not doing the same. And the patients, the consequences to the patients were catastrophic. But the needs in 1995 brought it up. And then two other protocols extended the time window from 3 to 4.5, then to 6 hours after the stroke onset. On the intraarterial side, the story was a little bit longer, although the strokes were first treated endovascularly with balloon angioplasty in the past. When we were trying to translate the results from the intravenous TPA studies to the intraarterial world, the results were not the same. So this is the study that I was talking about, the needs study. It first was validated for 3 hours, then this was the complication rates, and then the ECAS extended to 4.5. But still, despite intravenous therapy, there was a significant mortality still on patients with very large stroke burden. So carotid T, despite of treatment, still have a 53% mortality. MCA strokes from 27 to 78%, and basilar 56%. So the intravenous was not yet the safest drug to be used, particularly also because it only resolved very distal occlusions. The proximal ones were not resolved properly with the TPA. So then what was the goal to translate intravenous to intraarterial? The first study was called PROACT-2, which was a study that would go endovascularly through the vessels and place a catheter close to the clot, like this, and then inject the thrombolytics, urokinase or RTPA, and then dissolve the clot. And this is an example from a friend from Bern in Switzerland. The arrow is pointing to the occlusion. There is a catheter there. And after the injection of the urokinase, you can see here that the vessel was recanalized. So the PROACT-2 was very promising. It demonstrated 40% of good outcomes, still some hemorrhagic complications, but not that significantly. So there were different studies proposing different thrombolytics, and there was then an attempt to actually, instead of injecting lytics that would increase the rates of hemorrhages, to mechanically go there and extract the clot. And from the IA lysis to aspiration and distal devices, there were different systems that were proposed. And manual aspiration to aspiration with a system from Penumbra, and then distal devices. The first one was called Mercy, which is like a pigtail shape. You can see here in the picture. And all these techniques were used. This is the old family of aspiration catheters from Penumbra. This is a distal thrombectomy that we will go distal to the clot and then extract the Mercy device. Or this is a picture of a device from France called Catch. And these are different pictures of these devices that were used to catch and remove the clot. So first of all, the recanalization rates were improving with these devices. So we were able to grab more and more clots. And then there was the need to organize 3 randomized control studies with that first generation of devices. And these studies were called IMS3, MR Rescue, and Synthesis. And these were 3 randomized controlled trials published at the same time in 2013, and they were all negative. So, which means that all the devices that I showed you so far until 2013, these ones, they were not as effective as the lytics or as effective as the IE lytics. So mechanical thrombectomy had to wait a little more. But there was a game changer. We actually realized that these devices would remove the clot proximally, but there was a lot of distal emboli. You can see here the partial and complete recanalization, although the partial was growing, increasing, the complete recanalization was stagnant, the same, which was probably the result of the failure of these new devices. So then, at the same time, in 2007, there was a device that was used for brain aneurysm, which is called solitaire device. This was a device to be placed in the artery to support the coils inside wide neck aneurysms. In this device, during a procedure for aneurysm and complication with clot, remove the clot, and then it started to be used for stroke. So this is a picture of a device and how the stent open could bring the clot. And this is how it actually looks like in real life. And that was a game changer. To be honest, at the beginning, when I started doing those, I was afraid everyone that I told the story, or I was involved in the first cases and the first study with this device back in 2008 and 9. And whenever you would say that you would deploy a device and pull a stent open through the circulation, everybody would call us crazy. This is, you will dissect, this is impossible. But actually the results were pretty good because the wires of the stent were very small and the device didn't hurt the artery. And it could pull the clot, as you can see in the picture. And me and Jan Grala from Bern in Switzerland, we organized the first study of this new generation of devices that was called STAR. And we enrolled 202 patients, and we had a strict protocol. And actually the STAR showed for the first time that we could increase the complete recanalization rates that in the past, the previous studies didn't show complete recanalization rates. And also we showed that we were fast, way faster compared to the previous generation devices. And the result was clinical outcomes favorable of 57.9%. Then the next step that was required by the FDA was actually to compare the first generation devices with the second generation devices. And there were two studies, one called SWIFT, that actually tested the Mercy and the solitaire device. And the results were so good that the study had to stop early. And the solitaire was then approved in the United States with overwhelming results on both improving the clinical outcomes and reducing the mortality. So now, finally, we had the good technology to do faster and complete recanalizations. And then it was time to go back to the studies. And that was in 2015, 2 years after the failure of those studies, that with this new technique, we actually had simultaneously 5 randomized controlled trials with different number of patients that actually demonstrated superiority of the thrombectomy with a stent retriever compared to intravenous therapy. And this was the beginning of a series of studies on stroke. So then these initial studies, they treated patients up to 12 hours. Then there was Dawn study that increased the time from 12 to 24. And there were recently studies that increase the indication to large core patients that have already a big lesion. So in every single study that we've been doing regarding stroke treatment, the removing the clot with a device, if it's done fast and effectively, it's better than nothing, or it's better than any other therapy. And today there are two main techniques: stent retrievers and aspiration with large catheters. So the stent retrievers can be used with a balloon that temporarily closes the carotid, or it can be used with a catheter that goes very close to the clot, distal access catheter, and aspiration that can be just the manual aspiration with a catheter, or as an aspiration with a system. So this is a case, was one of the first time that the solitaire was used for a stroke. 62-year-old NIHSS of 18, 4.5 hours after the stroke onset, CT, an eventful perfusion showing a right side stroke, and angiogram showing, confirming that right side stroke, a carotid T lesion. Then the procedure starts with the navigation of a microcatheter, crossing the clot, then placing a stent. You can see here the blue arrows are the markers of the stent. The dark one is to show where the microcatheter is prior to remove the stent retriever. And this is the process of removing the stent retriever. And if you notice below, the balloon guiding catheter is inflated to temporarily close the blood flow while the device is being pulled to prevent the clot to re-embolize. And then once the device is inside the catheter, we disconnect. There is a small series of procedures that we have to follow to prevent the clot to be lost or trapped into the tubes that can, if it's not properly managed, pieces of clot can remain in the system and can re-embolize prior to connection. And you see here, after one pass, the clot was completely removed. In the first generation devices that I showed you, Mercy, Catch, this was almost impossible, would never happen, or rarely. And with Solitaire, this is the regular. So that's why these new devices have changed completely the scene on stroke. This is another case, 32-year-old patient, very young, presented with already some lesions, but good aspect score, perfusion, in the right MCA. So we used one of the long devices, and you see, because the patient was young, there's some vasospasm. You see that the vessels are a little bit irregular, but this is temporary. And the stroke was completely, the clot was completely removed. And after a few minutes, you see that the artery comes back to its normal status, just because the clot was removed, and the spasm of the device has it improves pretty quick. So this is the follow-up CT showing that the patient had no strokes anymore. The other technique is the aspiration. So the aspiration technique is going there and aspirate the device. There are different catheters that are used to facilitate the navigation of bigger catheters all the way up to the head. This is a video illustrating this process. This is a simulation of a clot on the left side. We usually go through the groin, but we can go through the wrist as well. I prefer the groin for strokes, except they are in the posterior fossa. And the whole process starts with the placement of the base camp, which we call the guiding catheters. We use select catheters to navigate those catheters up. So for many strokes, this is the most challenging part of the procedure. Removing the clot today with the devices we have is not the most difficult part. So once we are in the head, in the neck, then the second phase of the procedure is navigating the catheters that will perform the aspiration. And then this is what in this video we are seeing now. And you see here the pump and the catheter is very close by. And once the pump is inflated, then the clot gets or aspirated or it gets caught at the distal end of the catheter. And then we pull slowly, and or the clot comes or it comes with the catheter. Let me show you some cases. This is a 56-year-old patient, carotid T. So I navigated one of these first catheters close by, and you see here it was completely recanalized. This is an 82-year-old patient with a baseline NIHSS of 17, very tortuous anatomy. You see here the navigation of the catheter through the aortic arch. And again, this can be the most challenging step of these strokes, particularly in an 87-year-old, 82. So once the system is placed in the neck, in the ICA, then we navigate the large catheter. In this case here is ACE 68, a penumbra catheter, until very close to the clot. And then we turn on the aspiration system. You see here, there is a little bit of clot, but there's no blood flow. This is a sign that the catheter is holding the blood clot firmly. And I usually wait 3 minutes. And after the first pass, I didn't reach final recanalization. Then the second pass, I'm pulling slowly. Yeah, this is a good sign. This is a sign that the clot is coming down there. And as you can see here, the vessel was recanalized. Sometimes there's some spasm. We just wait a little bit. This patient had an intracranial stenosis as well that we treated. And this is the result at 24 hours. So those are the two basic techniques that we have today. There are tons of different catheters, tons of different stent retrievers. That is not the case for us to talk about all of them, particularly for a young crowd from neurosurgery. But it's for you to understand that this is a whole new world. 20 to 30% of the endovascular activity in many hospitals is now related to stroke. And many centers here in Canada only hire neurosurgeons with endovascular training because they need help to join the stroke call. So this is something that we are doing quite a bit, training colleagues to help with the stroke call, because this can be quite extenuating if it's done by the team that has to do elective cases as well. Now, I will talk to you a little bit of what's coming next. So I don't know if you've seen that I do a lot of research on robotics. So we've done a number of brain aneurysm treatments, and there's a new generation of robots coming. And the aim of robotics is to facilitate the procedure and make like devices like flow diverters deployed consistently without technical mistakes. So this is one study that we published 2 years ago that demonstrated the safety of a robotic system from Siemens in 117 patients. And robotics, it does improve our performance as a surgeon. But also what is interesting for stroke is that it can possibly expand access to care. This is the distribution map of United States. And you can see here that 80% of the map is not in an area of United States that is good in terms of timing to get to a stroke site. So John, I hope you have a good hospital close by, but if not, most of the American population, it's not in an area that can quickly get to a stroke site. So it's not a problem only for poor countries or developing countries. It's a problem of geography. So here in Canada, we have also the issue of vast geographies. This is our province, Ontario. And just by doing telestroke, we could increase the coverage of a stroke consultation. But you see here, the time to get to a stroke assessment it's around 3.5 hours. So, and a study from the World Stroke Organization have demonstrated that the challenge for access to care for stroke is actually the availability of the operator. And although we cannot train everybody, and there's a lot of studies demonstrating that it's better that someone doing stroke is someone good instead of training a cardiologist or a body interventionalist, we cannot train everybody to cover the whole world in terms of mechanical thrombectomy. And that's why we've been proposing doing telestroke. So having the robot that we know that beside the patient, beside us, can perform many surgeries. But now we want to know if they can perform surgeries remotely. 3 years ago, we got a grant, and I built a team to study remote robotics. We even built a small robot that we did simulated surgeries, and we tracked different simulated parameters. And we actually defined what is the latency, what are the good conditions. And I think we would be ready, except the fact that we don't have the right robots for a stroke. This is the robot that you saw me operating at the beginning. And this is my son when he was 5 years old doing a thrombectomy. The issue with this system there is that we had to place the catheters in the neck, and the robot could do everything intracranial. But, if the most difficult part of the stroke is to get up to the neck, if the system is too short, it's not an ideal system for stroke. That's why a lot of companies are working on second and third generation robots that will actually have long pathways and can perform a stroke after the groin puncture all the way up to the head. So those systems, they are on development. These are the systems that will be ideal for the deployment of remote and the performance of stroke robotic technology. Siemens is working heavily in system. We have a room dedicated for remote robotics. The room is ready. These are the pictures here. We've done a number of experiments with a couple of devices, prototypes, and we've done already some preclinical, very good and promising work. Last year, we did a demo from us here to Buffalo, where Dr. Siddiqui is, and we did a remote thrombectomy in a simulator from there, from Buffalo. And early last year, I was in Abu Dhabi, and I also did a thrombectomy with a robot that was deployed and placed in South Korea. And to be honest, that was the first time I did something very distant, but I had tested the day before, and the quality of internet was very good. We did it all in a simulator, in a silicon model. In blue here was the clot, and I was on the stage with all the authorities. And this is Fred Moll, one of the inventors of the surgical robots, and probably the responsible for most of the robots in surgery that we have today. He was very impressed. I removed the blood clot, and this is the team in Korea. So this will be the future of stroke. So be prepared. And something else that we are also evaluating is something that is called OCT, which is an endovascular imaging modality, which is a catheter that has a laser that can read the images from the vessels. And we have very precise images that will help us understand a lot of the diseases that we see in the head. This is a patient with a stroke that we didn't know if it was a vasculitis, a dissection, or a blood clot. I didn't want to pull a device, and I put the OCT, and I saw that there was a blood clot. The vessel was intact, and I actually could remove the clot safely. So in the future, we will have all these new technologies to make the thrombectomy even safer and better than it is. And in areas that there's no capacity to have a full trained neurosurgeon in endovascular, remote robotics can be a solution. Thank you very much.
Okay, Abdel?
Okay. Thank you very much, Prof. Vito Mendes, for excellent presentation. I have some question.
Yes, I'd like to comment right away, Vito. First of all, thank you very much. I wasn't aware of the robotic development. It's certainly exciting, and I'm from the era that you were from. When I trained, we just put stroke patients in the corner and just would watch them, would they recover or not. That's all we did. And then aspirin, and then, of course, the thrombolytics, etc. I'd like to introduce a brain surgeon that's part of our team now, Neurosurgical TV. You perhaps know him, Atta Bhatti from Switzerland. He's going to be running our dual neurosurgery channel, and I'm sure he has some comments or questions he wants to ask you. Hello, Atta, welcome. You're muted, Atta, you're muted, muted. Unmute.
Prof. Vito Mendes, I have some
Hold
question.
hold on, Abdel. Atta's trying to go ahead, Atta.
Yes.
Okay.
Yeah, hi, John. Professor Vito is among pioneers, so it's a pleasure listening him, and it's wonderful talk. Every time I hear him, it gives a great piece of knowledge and impressive work done by him, and he's a very good mentor, I must say. So we are lucky that we have an opportunity to have him in Neurosurgical TV, and I hope we will be more connected to him in the future too.
Thank you, Atta.
Thank you. Thank you. Okay, Abdel.
Okay. Okay. What is the future role of robotic assist interventions in expanding access to interventional stroke care?
I think it will be, once these technologies will be developed, this will be very critical to expand the access to stroke. So, and a robot is cheaper than a surgeon. So sometimes, you know, to have a neurosurgeon or a neurologist that is trained to stroke, you need to make sure that they have elective volume outside the stroke hours. And this is something that we have to be mindful of this. And then you need 3, 4, 5 physicians to be able to run a 24-hour service. And a lot of places, you can't afford that. And if you have one robot that's connected to a center, or for example, in Yemen or in developing countries from Middle East, you can have central areas where you can just, instead of training someone to have a low volume in a small hospital, you just place a robot and centralize the care. So I think there's a lot of potential of development when remote robotics will be implemented.
Okay. Question 2. Question 2. Discuss the ethical challenges involved in perform emergency in hero interventions on patient unable to provide informed consent.
Yeah, because the stroke is so critical, and usually you will do that in a place where the patient will take hours to be transferred. So I think there will be not much discussion. It's better for the patient to try, because the number needed to treat, which is the power of the mechanical thrombectomy, is very low. We are talking about one of the most effective treatments. Even if there are complications, you can transfer afterwards. And most of the complications can be managed with the robot as well. So I don't think it's a big deal, but obviously we will have to do studies to prove that.
Okay. Question 3. What are the empirical criteria for selecting patient for mechanical thrombectomy rectal beyond the traditional time 1 day?
So it depends on the site. So now we are joining studies that enroll strokes up to 5 days. So we use a lot the imaging and less the time window. So the time window is mainly for guidelines, for the patients to be considered, the neurology team to be called. But we actually treat any stroke anytime. And all the studies have been shown that, except for the low NIHSS, so the patients that are mild despite of the clot, they are not as symptomatic, then it's better remove the clot than not. So I think that's what we are.
Okay.
Okay, I have a question. I have a question here.
2.
Go ahead. You have another one?
Question 4. What are the major challenges facing interventional and radiology and resource limiting setting, and how can they be overcome to improve stroke care? And so on.
I think the main the main point is the cost of the devices, I think, and the training of the
Mm,
population. So I think if the cost is not an issue, obviously this is a treatment that should be used and offered to anyone anywhere. But I know that the challenge of approval, the challenge of uh, of getting the devices reimbursed, that is what it makes, and sometimes even the challenge for imaging, having contrast imaging, it's a challenge in some regions. So I think it all starts with an organization, and I think the stroke neurology and neurosurgery, interventional neuroradiology have to uh, pull forces together to work with the government to get the public systems aligned, the guidelines created, and that's how all the big success stories on stroke happened.
So it's a big political
okay,
issue, political and financial.
okay,
It
Yeah,
takes a
big time.
while to get a center.
okay. Thank you very much. I am very proud and honor to meet with you.
Thank you.
Okay, we have another question. Suresh, do you have a question?
Yes,
Go ahead.
I am Suresh Mathuria from India.
Hello.
I was working in Postgraduate Institute of Medical Education and Research, Chandigarh. We had the stroke program, as well as we had been operating the largest number of aneurysms in the country there,
Oh,
which we
wow.
are doing at present. I am retired from that place. And fortunately, I am in Toronto only at present with my daughter for some time.
Okay.
And congratulations for the great talks covering on the stroke as well as the posterior circulation aneurysms. And definitely the remote care of the stroke by intervention is going to be a panacea for managing the stroke patients. Because whatever you call, you might be calling about 5 days or 4 days or 1 day, whatever it is. Earlier the patient is managed, the better is the outcome in the penumbra. I think you will agree with me on that. And for that, that can come only by the remote. And the remote, obviously, the robotics, which we have talked about. The initial expenditure is going to be extremely high, but definitely the subsequent expenditure is going to be low as far as the personal care by a neurologist, neurosurgeons, or an endovascular neurosurgeon is concerned. I think Professor Pereira will agree to me on that. As it was asked about what is the time and all, it will depend on what is the diffusion perfusion mismatch on your study, and what is the location of the infarct, and whether the infarct has appeared in the FLAIR image or not. I think, Dr. Pereira, you will agree with me on that. That will decide your further management and the outcome in the stroke patients. One thing the question, Dr. Pereira, is what is the stroke patient in whom you did the intervention the longest possible and the patient made a good recovery?
I've treated patients between 3 and 5 days.
Wow.
We are
nice.
starting now a randomized study. So if the imaging is intact. So what makes those patients survive with the brain of those patients survive is the availability of collaterals. So patients with good collaterals, they can tolerate the stroke for a long time. So I think that today, so although I'm a big fan of perfusion and I use it all the time, the guidelines are stating that you don't even need mismatch on perfusion. So the large core trials, they state that unless aspect scores 0 to 1, you can treat and you should treat. So I think everybody has been very encouraged to continue and push for strokes. After, once we have different setups with robotics, without. I think what we are doing here in Canada, what we do is we do a lot of telemedicine. Even before robotics, we had telestroke. We have a big telestroke network. So every emergency in the province, almost in the country, will have a remote neurologist that they can consult. I do neurosurgery call, and when I'm on call, any emergency doc in the province can call me with a subarachnoid hemorrhage or a tumor, and we give them advice. So I think telemedicine is something to be developed. It's not expensive.
Oh, yes.
Yeah, and it will certainly improve the care of these remote locations.
Telemedicine is mandatory for all the intracranial lesions. There is no doubt about it, and much more about the vascular lesions in the brain. And the maximum is about the stroke. I think you will agree with me on that. And as you told about the intervention in the posterior circulation aneurysms, I think you must be knowing about the history of posterior circulation aneurysms. The greatest job and the greatest work and the best results produced till today are from London, Ontario by Professor Charles Drake. I think you might be knowing about that.
I do. Yeah.
And the same thing, if you are doing the same results here in Toronto by the different techniques, it's an addition to the work which he has done in London, Ontario.
Yes. Completely.
Thank you, Suresh. I have a comment. One of the things that really surprised me, Vitor, was we do webcasts with China, and Bin Zhu, who you probably know, he does about 10 bypasses a day, very busy guy. He mentioned that artificial intelligence is the future of neurosurgery. And I would think, what the heck does he mean? There's so many intricate movements. How can it? And as you know, robotics is tied to AI. And when AI started developing, it seems that robotics got stronger, got more precise. Did you notice a difference when AI came as far as the progression of robotics? Did you notice it?
So robotics is being used a lot, and a lot of automated functions already help us during these procedures. And there is a robot from a company called MMI that is proposing to do neurosurgery bypass. They are starting a study here in US and Canada. We are joining it, and I'm not doing surgery much more because I do endovascular, but I will go back to bypass with the MMI robot because it makes it seamless. And actually, the robot has microsurgery instruments, and it's used with an exoscope. I think obviously now it's a very expensive technology, but in the future, all these very delicate techniques that can only be performed by few surgeons in the world will be spread and diffused with robotics and endovascular as well.
Oh, okay. Arthur, you have a question?
Yes, I just want to re-echo the words and thoughts. It's nothing to add additionally, but totally agree that the geographical situations determine the outcome of diseases. Unfortunately, we live in this world. So regarding the cost issues, I don't think many countries have a restraint of cost. It's the prioritization and something from our side also. Our voices are not that strong at policy making stages. So we are not part of the whole allotment of funds, and just because of that political fragmented approach, we are missing the opportunity to grow in many countries. So in Geneva, we are working in lower middle income countries as target to improve neuro health care with the base as neuro health care for LMIC. So this is where I got connected with John. So what we are doing is we are trying to establish terms with the ministries and tertiary care hospitals and professionals. So far, we have a good group of people who have a better voice in their systems. So one of the main issue is before setting stage for neurointervention or neurovascular complex procedures. So there are a lack of basic human care trainings and resources, and basic procedures are not being done. So there is a lot of health tourism for cases which can be managed in a different way, where the operators would remain a part of follow-up, and continuity of care won't be lost. So I think the Vito is working excellently on that model to bring in more technology. So the many countries can buy, like one of the small country, Botswana, they don't have issues for buying new technology. But what is happening that they have a neuro-oncology setup. They are buying radiation machines, and the similar setup can be accommodated for other things. The missing link is our voice. So I would love to interact in future to have to look the possibilities where we can work together. Thank you so much.
Okay, all the best. Yeah, happy to.
You know, Vito, I know you're pressed for time. I'd really like to thank you for giving us the time, and we need to wrap
Can I
it up.
ask a last question?
No, sir, we can't. You can email Vito if you'd like.
Oh, sure.
Yeah, you can email Vito if you like. And Abdel, do you want to wrap it up, please? Are you there, Abdel?
Okay.
We're finishing.
Okay.
The doc's got a busy day ahead of him. Go ahead, Abdel, close it up.
Again?
Yeah, close it up again.
Yes.
Okay, I guess we'd like to thank you, Vitor, and we'll be seeing you in the future. And thanks everybody
Thank
for
you.
coming.
Bye-bye. Thank you.
Okay. Thank you, everyone.
Thank you.